without further ado, I will hand over to Patrick to introduce the session. Thank you very much for agreeing to chat. Patrick, it's much appreciated.
Thank you very much, John. Good afternoon, everybody. I'm Patrick Mitchell. I'm the Director of Innovation, Digital and Transformation at Health Education England. And we're delighted to be doing pieces of work with CLEAR on workforce transformation at the present time, particularly in the mental health field. This afternoon is around looking at various case studies of transformation that's taking place, trying to get a sense of what's worked, what hasn't worked, what we need to think about for the future. And in setting the context, I think if we look back at the way the NHS has looked at workforce in general, we've always designed our services around the healthcare professional. And that was the right thing to do at the time. But as we move forward, and particularly cognizant of how digital transformation has worked in other industries, I think now the time is perhaps to think differently about how we design services around the customer. So in our case, the patient, actually in HE's case, that's the learner and the educator. But for the purposes of today, we're talking about the patient and how we think about that and design around them to think about a different way in which health services can be delivered. If you look at how travel and banking and retail use digital transformation to really put their customers at the center, their customers now we the citizen take responsibility for doing the data entry for what we want from those services, and in return we get those services much closer to home. I think this is something that we in the NHS now need to look at and to learn from those organisations to see what would work in the NHS and how that might work. And I think we've got a great opportunity this afternoon to hear from a few case studies of how transformation has taken place and how people have thought about not only about the healthcare professional, but also about the patient and how we put them at the centre. The other thing I'd say, learning from COVID, is we had to work quickly to actually deploy skills and capabilities rather than professions. And again, this is an opportunity to rethink how we plan services around what are the skills and capabilities we need around a given care pathway in a place to make something happen, and how do we make that happen, rather than trying to plan it on the old style, X number of doctors, Y number of nurses, and then a fill-in of the AHPs and the pharmacists around the edges. So again, I hope from this afternoon's conversations, we might get into some learning about how we really do think about skills and capabilities and how we deploy them, and not just about the healthcare professional per se. That's all I have to say as way of introduction, because it's far more important to get into, I think, the case studies. And absolutely delighted to be able to introduce our group of people speaking today. And our first is my good friend, Dr. Nav Chana, Clinical Director for the National Association of Primary Care, who I know will have great things to say about his own case studies. Nav and I go back some time when I was working at St. George's, and we did some very interesting work looking at how physician associates might support primary care. And in those days, there were only 20 physician associates in training when Nav and I first started talking. I'm pleased to say we're pumping them out at over 1,000 a year at the present time. So that's a major change in less than a decade, going from one course at St. George's to 36 courses across the UK today. So, and regulation on its way very soon. So in a way of introduction, over to Nav. Good to see you, Nav. Thank you.
Thanks, Patrick. Thank you very much to all of you for having me on your round table. So Patrick, thanks also for that warm introduction. So mine's less of a case study, but probably just an outline of some thoughts, which I hope will then tee up a couple of colleagues who've kindly joined the panel, particularly Arvind and Pramod, to perhaps describe the detail in a little bit more at greater length. So Patrick, as you know, thank you for remembering that all those years ago when we first spoke. I've just now completed 30 years as a GP in East Merton, and Patrick, you will probably not be surprised to know that across that 30 years, the health inequalities of the population that I look after has got worse, not better. Let me repeat that. It's got worse, not better. And that's kind of a sad legacy to think about as I contemplate retirement. And I offer all of you the opportunity to perhaps other than discussing these things, as we always do interminably, to actually think about how we move to practical action to address some of those challenges. So here are the things I wanted to speak about, Patrick. My observations over my career as a frontline clinician have suggested that the reason that some of the transformation programs and all the talk about innovation and integration and all these wonderful things that we describe at great detail haven't worked is because of just three very simple things. One, we haven't engaged clinicians on the front line sufficiently, because it's the clinicians who are on the front line who commit the resources of the NHS. And often we do unto them, we tell them, we don't actually engage them. So the sense that perhaps we need to do that bit a bit better. Secondly, whilst absolutely the care of the individual is important, it's in the context of a population health responsibility. We can't just focus on the needs of the individual without thinking about cash limited or state limited funds and how we improve the overall value of what we're thinking about. And then the final thing, which, this is not by any means the end of the story, is a complete lack, in my view, of integration between primary and secondary care, particularly across those 30 years that I've been a GP. And goodness knows, Patrick, we've spoken about it many, many times, haven't we? But actually, have we done enough about it? That's to be debated. So colleagues across this group joined me to create what we call a frontiers methodology. And I want to just kind of highlight some of the 5 things that sit within that. The first is that, as we probably all would agree, any change needs to be clinically led and driven by data. And I'm sure all our data people will be very delighted by that point. But data is just enough data to get on and do something, rather than collecting more and more information to actually kind of paralyze what we're actually wanting to do. So there's a sort of slight challenge to everybody on that point. The second point is that we need to create a common sense of purpose, both at place or neighborhood, at whatever level of integration we're talking about, because it's that common sense of purpose that binds us and clinical teams together, rather than thinking about silos and sectors in the way that you were describing earlier. The third is that we actually need to support colleagues, both clinical and managerial, to really understand the benefits that technology can provide for them and the opportunities that technology creates. So we create a sustainable system which is not so dependent on individuals working their socks off. The fourth is about genuinely thinking about collaboration across providers. And again, trite and oft said words, but actually, are we really focused on collaboration in the true sense of the word? And I would suggest we probably aren't, because we're driven by metrics and measurements that drive us apart rather than bring us together. And there's an interesting example from Denmark, where actually the quality of the collaboration between providers is a metric that is used to emphasize the right sorts of incentives. Now, wouldn't that be interesting for us in the NHS? And then the final point is actually no change happens or is sustainable without a social movement philosophy behind it, so that how we leverage networks and networking opportunities where people connect, share, respond, learn, and do together without top-down directives being the primary means by which change is kind of thought about. So I offer those 5 points, Patrick, within my 3 minutes, because I know that Pramod and particularly Arvind will contribute more in terms of the practical meaning of some of the things I've been talking about.
Thank you, Nav. Great contribution, and look forward to returning to some of the points you've made there around your frontiers methodology. Our next speaker is Professor Sam Shah, NHS consultant at the Royal Wolverhampton and Chief Medical Strategy Officer at Newman. Again, Sam and I go back some time, and look forward to hearing from you, Sam.
Well, Patrick and John, thank you for inviting me to this session, and great to see everyone and hear about it. Probably just by way of introduction, I still luckily work both in primary care, a little bit in the acute sector, and then in a digital health organisation. So I sort of get to see the system from all sides of it. And the dimension to this that I think will be interesting for you all, that I really find fascinating, is how do we use data and technology better for both planning purposes and also for workforce purposes? And I think the two go hand in hand. If I look at what happens across public sector, typically our failures come from a lack of strategy, a lack of organizational design, and very few resources allocated to the outcome we're looking for. So it's great to see programs such as CLEAR, led through HEE, where this isn't necessarily the case, where actually there is a strategy, there is a design, and there's most certainly resources allocated to make it work and support individuals in the change. But just going back to something Patrick mentioned earlier, and that's the consumer dimension. And I'll share with you 2 case studies. If I think back to when I was outside of healthcare in retail technology, one of the things that we can learn from is what happened in retail and logistics, and a lot of the learning that came from other sectors, in fact, the military and from air traffic control. And if we think about why this happened, why we got digitization and technology change there, it was to get things to consumers a lot faster. Well, is there something we can learn from in the NHS? Absolutely. If we take something like urgent emergency care, something that all of us in every part of the system see and hear about every day, we could certainly take an approach where we take something like an air traffic control system and apply that learning into urgent emergency care. But it requires a fundamental shift in thinking and culture. It means we have to think about removing the boundaries between primary care, secondary care community, between an ambulance service, between 999, 111 and out of hours, and actually think of it as a system, bringing together data, more importantly, engaging with clinicians throughout this, and making people have visibility so that we can effectively make change happen. That's the first part. The second is the flip, almost opposite of that. If I think about consumer healthcare, an area that I'm working in at the moment, one of the things we've learned about is the practicalities of giving consumers, citizens, what they want, what they need, reducing friction. Now, that doesn't mean we should be completely a want-based service, but certainly designing services around citizens and ensuring that we recognize that we provide data both actively and passively as citizens to a health system, and allow technology to be built and designed around that data so that people can make decisions more closely for themselves with the support of a skill mix of clinicians. Certainly something I've seen in organizations that I work in, we use a complete skill mix of clinicians, everything from OTs and pharmacists through to GPs and specialists working together where there are no boundaries between those individuals. And something as simple as having their bloods taken, analysed, and having the full support of a clinical team working together. So I certainly see a future where we use data and technology to support consumers of healthcare, citizens, get better outcomes, but doing that with a different workforce and using data in a different way.
Brilliant. Thank you very much, Sam, and good to see you and to hear those thoughts. Our next speaker is Panesar, Deputy Director of Strategy and Development, Data and Analytics and NHS England and NHS Improvement, who I have no doubt is going to continue this theme around data and how we use data. Over to you, Suki.
Patrick, thanks for that. And Sam, thank you for raving about data and analytics. So that's a good intro. So I think very quickly from my perspective, I work as a Deputy Director in NHS England and Improvement. And it may surprise some of us on this call that we actually have 600 data professionals and analysts working at the centre. And generally, we tend to be very much, as I would say, upward and sideways focusing, but we probably need to do more with the real world out there. And that's been one of the huge narratives that we've not just been trying to, talk about, but actually enact at a very practical level. And I think most of you will understand that during the pandemic, it was probably a galvanizing moment for the analytical community. Never before had we seen such a huge demand for sophisticated analysis, game-changing insights, and I'd like to think some of those resulted in good decision-making, but again, I suppose that's up for debate. But what we noticed that was very important was the analytical community found itself working in a very different manner. So, and what I mean by that basically is moving away from its silo-based way of working to actually beginning to, dare I say it, share some of the code, share some of their modeling assumptions, and trying to deduplicate a lot of the stuff that we do in the NHS, where you will create 42 versions of almost similar things, or 200 of provider organizations doing the same thing. So what we started to do in NHS England and Improvement was how do we enable this, not only from a tech perspective, but from a cultural perspective? Because you'll find at the end of the day, the tech is not too much of a challenge, and I say that with with caution, but generally tends to be more of a cultural piece. And we perhaps set ourselves a very low bar as the data and analytics team in NHS England and Improvement, which was around mid-March, where we were told we'll all be working from home at the start of the pandemic. And essentially, we wanted to create a safe environment for our analysts to start sharing ideas, sharing some of their code, their dashboards, and doing the stuff that most of us would do in our normal lives outside health and care, which is sharing and collaborating. And we leveraged the Future NHS platform, which is one of our online collaboration platforms, only ever really expecting 50 of our analysts to take part in this experiment. Rather than saving things on their local hard drive, they could basically save it on this online collaboration platform. So to cut a long story short, I think we have been really humbled by what turned out to be a very simple experiment to what has now grown into Analyst X, which is a very large online collaboration community of 16,000 data professionals and analysts. And some of you on this call are actually members of Analyst X. And not only have we been able to work across ALB, and nor was it a directive to force all ALBs to work together. I think it was just like-minded people wanting to come together and do something. But I think what we've also managed to do is bring the private sector in and the third sector more in the spirit of learning from each other. So we find ourselves fortuitously having signed up 37 strategic partners, including the likes of Google, Microsoft, and AWS, who have very much wanted to try and shape some of their learning materials actually to upskill the data and analytics community, because where we are now is probably not where we need to be, and certainly where we definitely should not be, in the next 3 to 5 years. So that is our story, Patrick, of Analyst X.
Fantastic, thank you, Suki, and really good to hear of that new collaboration between, in terms of bottom-up data analysts coming together to want to share and feeling safe to share in a way that allows the thinking to grow. So really interesting. I'm sure we're going to get into conversations about that this afternoon. Our next speaker is Kathryn Perara, who's the Director of NHS Horizons. So over to you, Kathryn.
Thanks very much indeed, and it's a real pleasure to be here. I think what I would like to do is, in the few minutes that I have, maybe just reflect on what Nav prompted us to think about. Nav, I think you put it beautifully. You talked about the space for transformation and the inhibitors, but the space being data and just enough, which is a theme that then developed. Clinically led, metrics that point us towards genuine collaboration, and social movement approaches. So the meaning of the word to transform, transformation, not being incremental improvement, but moving us from one way of being towards a different future, and being able to mobilize people in the NHS and those invested in health and care towards a radically different conception of what that future could mean. In my role at NHS Horizons, I lead the design strategic facilitation of lots of different work. We work across probably 30 to 40 different subject matter areas at any one time. And I think that gives us the ability to see widely rather than deeply, and to see the commonalities of inhibitors for transformation, genuine change from one way of being to another. And one of the things that I see is that in healthcare, we are at the nexus of some of the biggest revolutions historically that are playing out in all of our work, digitally, genetically, biological revolution, the social learning revolution, and how all those things come together. And that can feel, for many of us, for people working in the NHS, overwhelming. So the one contribution I wanted to make, really, one point, I see the future of work in change, the future of truly transformative ways of being, and then through that doing, being about this one central insight. We need to pay as much attention to how we think as we currently pay to what we know. What I mean by that is the currency in the NHS, I believe, is predominantly about technical competence, the acquisition of skills, empiricism, tried and tested evidence-based methods as the dominant approach, and those things are critical. And yet alongside them, our ability to learn and yes, to teach and to coach in how to develop more complex, more subtle ways of knowing and understanding, how to collaborate across boundaries, how to lead from the emerging future, and how we do that together, to listen to what is happening right across our specialisms and develop the skills to lead in different ways. I believe that that aspect of change, the way that I think, not simply what I know, is going to be critical. So that was the one thought that I wanted to offer.
Thank you very much, Kathryn. Some great point there around how to think and changing our thinking about how we spend time on that. And again, I'm sure we're going to come back to that one during this session. Our next speaker is Dr. Pramod Prabhakaran. Hope I've pronounced that all right. My apologies. Consultant psychiatrist from Central and North West London Foundation Trust. Over to you, Pramod. Welcome.
Thank you, Patrick, John, and thank you, Nav, for inviting me. Just a brief background. So I've worked at Central and North West London Trust for over 20 years now, as a consultant for the last 16 years and medical director for one of the divisions, which was quite a dynamic division and helped me learn about the complexities and challenges of transformation, but also adoption of any new business model, be it digital, be it change to how we work, change to pathways. I wanted to start off with a story based on some of the leadership work we did at CNWL some years back. So a program was designed together with Imperial College Business School to look at leadership for clinicians. And it was during the time of cost efficiency and financial pressures. So often the task for the leaders were to try and find efficiencies within their services. And often they were presented with anonymous data, which they had to study and come up with some solutions that could help improve quality of care and also be cost effective. And the clinicians were excellent. They very quickly came up with very logical solutions. And then we told them that the data actually belonged to their own services, which they had access to for forever, and they hadn't acted upon that. So I think having data is important, but having data that you can action is more important. Having the leadership buy-in to support clinicians in doing that. I think that was our journey of clinical leadership, which began many years ago, and led to, I think, a reasonable cadre of clinicians who engage with data, who were able to not be put off by spreadsheets. Now it's much better visualizations, but not be put off by spreadsheets, but to actually engage with data. So that was in some way the leadership journey that started many years ago across the trust. I wanted to highlight two examples of what I would say was relatively large scale and complex transformation. And going back to Nav's points around the frontiers work, Nav, it highlights really a number of those themes. So one was in Camden, going back about 6-7 years ago, where we looked at integration between services. And Camden is a complex health ecosystem with 2 large acute hospitals, community provider, primary care. But the leadership that was brought about by the CCG at the time, using what was intergenerational data to look at 3 areas: mental health, diabetes, as well as frailty. The common purpose was really around outcomes and equity. So we had, I think, the first iteration in London of really focusing on patient-level outcomes. That brought clinicians across the system from all the acute hospitals, community, mental health together. So that system leadership was enabled through a leadership at the CCG, but with data and the common purpose of outcomes. And system leadership became a significant part of our action learning sets, because it was really, it was not command and control. It was being able to influence, to collaborate, and actually to motivate people. So the transformations in Camden around diabetes led to the first outcomes-based contract for diabetes, so that the organizations have a lead provider structure. So they are all jointly accountable for an outcome. And it sort of translates to the thinking around place and neighborhood now. The other larger scale transformation that I was personally engaged in was with the single point of access for mental health services across the 5 Northwest London boroughs. So each borough had a different structure for accessing services. In fact, 70% of the budget was held within the central London boroughs, and 70% of activity with 30% of budget was in the outer boroughs. So the common purpose, the unifying purpose was equity there, equity leading to quality of care. So we were able to bring even colleagues within CNWL from different boroughs for that common purpose, and also bring CCG commissioners and other partners together on that journey. That again was a complex transformation. It took time, but it was enabled by a good attention on data. One thing, we talk about leadership, but leadership, clinical leadership has to be enabled, but we need clinical, operational, financial leadership to have a joint sense of purpose, and to be really supported by the very senior leadership in whatever environment it is. So that senior leadership buy-in to support more frontline leadership, to collaborate is I think the key. And I would end by saying that what I distilled from some of these examples was 3 words: A, M, and O. So you need to have the ability, the motivation, but more importantly, the opportunity to do things. So I'll pause there and come back to discussions during the roundtable. Thank you.
Thank you very much, and great example of place-based planning using data. Thank you. Now moving on to Dr. Arvind Mohan, Consultant Orthopaedic and Upper Limb Surgeon of Croydon Health Services, NHS Trust. Arvind, welcome.
Thank you very much, Patrick, for giving me this opportunity, and to the whole panel to share my thoughts. I would like to echo the thoughts of Nav, and I would say I haven't done as long as he's done in the NHS. I've only done 18 years, but I'm still starting to feel that what sort of legacy I will leave behind, and I don't see change. My feelings are quite similar to what his are. And I look at it even a step further, that I will be at the receiving end of this health service in the next few years. So, I want to leave it in a very healthy way. So I guess my journey has been slightly different. I would say I have had a bit of a unique journey, because I trained initially in India and then subsequently went through 2 different training programs. I probably must be among the very few orthopedic surgeons in the UK, or probably in the world, who have had the unique opportunity to train in primary care and then in secondary care. So I've done the journey twice, and I've seen the primary care and I've seen the secondary care of the UK. And I think there are immense strengths in both the systems, but I always felt that having crossed borders from primary care to secondary care, I would find, and I would make it happen in terms of integrated working. But I have found it extremely challenging, even having worked within both the systems. And the biggest challenges I felt was that there is that sort of constant sort of fear of the other, which I don't understand why. But I feel sometimes there needs to be more work done on that so we can really melt these boundaries which exist between primary and secondary care. And I think would remain the biggest sort of things in terms of integration. And that pretty much sort of goes into my work in musculoskeletal medicine. And I have looked at MSK medicine, that why at all, with all the sort of resources we put into the system, and yet we can't achieve what we want to achieve. And drives me down to the same thing. Can we throw more money at the system and we can make it better? But as time has gone by, I have very strongly believed throwing money is not going to make it any better. It'll even make it more complicated. And as it makes it more complicated, its productivity will really go down. And that really goes into our sort of frontiers things of thinking in terms of the strength of data. So I think the strength of data remains paramount, but as time has gone by and as technology has evolved, our ability to make the data more granular in terms of how we can use it for our productivity remains extremely critical. So we can then focus our energies, focus our resources, which are limited, into those areas where it will do the best. From a clinical point of view, I strongly believe in the principles of get it right the first time, but I feel that we should get it right the first time right from primary care level. And that's where I sometimes feel from an MSK pathways, we have put in many pathways at the moment, which means that the patient journey has been prolonged. It might have decreased the referral to the secondary care, but many patients do find it very frustrated, stuck within those convoluted pathways which exist between primary care. And here we are in the world of integrated care. If we can create those systems and shorten those pathways by more integrated working, I see there is a huge potential in terms of improving things. I mean, I quite like the concept of air traffic control, and I think there's a lot of that which also lends itself in terms to surgery as well. And one of the concepts is from Formula One. So in terms of how we can use having this kind of the pit stop approach where we don't waste time, we create pathways which are very slick, which are very fast and very quick. And the whole idea is to get the patients back to doing things, especially with MSK problems, so that improves productivity. And we don't lose that sort of things in terms of patients who have had to wait in these pathways for a long period of time. And in many ways, with this integration, it would also lend itself for training purposes. And as we discussed about your experience with the physician associates, we are looking at primary care first contact practitioners in terms of MSK pathways, how integral that would be in terms of reducing the pathways. The Canadian models have shown that they work very effectively. And we have seen with our initial studies in the UK that we can really create, that would take the work from our primary care colleagues, and we can create these more integrated pathways where we can bring the secondary care close to primary care and shorten those pathways and get the right treatment for the patients. And I think there is a huge potential in terms of developing those things, but not only doing that would help in terms of our patient care, but has a huge potential in terms of teaching and training of our colleagues in primary care, whether it be the therapists, primary care physicians, sports physicians. It just has got a very unique sort of opportunity to develop those things. And in that process, we're actually creating a health system, which in the world of COP26, has to be much more green as well. There is no point of patients traveling from hospital back and forth. And then, whereas if we can move closer to those patients in an integrated care model, we would not only be addressing that and providing a health service which is for the next generation, but a much more greener healthcare. And with my role as an upper limb surgeon, within the sort of the remits of orthopedic surgery, I see that there is a huge potential to create a much greener, much fit for purpose care pathways for the future. And just on a concluding note, I would say that leadership, as we touched upon, it's one of those things, I don't think still as consultants, the opportunities available in terms of developing leadership models is still there in the NHS. And I think that's another area where we need to work more hard in terms of creating more leadership training academies for the consultants, and those can then drive the change for the next generation. Thank you.
Brilliant, thank you. Thank you very much. And clearly a theme emerging both on what you and Pramod said around, we've still got systems with a lot of redundancy in place. And if we can try and remove that redundancy in pathways and try and breach the difference between primary and secondary care, then the opportunity to make it far more streamlined for us as the consumer, the patient, the better, and for the people that are actually managing those pathways. So again, I'm sure that's a theme that we're going to come back to later in the conversation. Thank you. The next speaker is Claire Brewster, Frailty Specialist Nurse and a Clear Delivery Lead. Claire.
Hello there, thank you. Thanks for your time, everybody. And it's been really interesting listening to all the stories so far. A little bit about me, I'm in my 31st year of the NHS working. As Patrick said, I'm a frailty nurse, but I've been a senior nurse in the organisation for over 20 years. And within that, I've done matron post in ED, and I've worked in patient flow around bed management, and the air traffic control system would work really well if that could get that model right. Our trust joined CLEAR back in 2018, and we wanted to look at urgent and emergency care. And we all knew within the department that we knew what the problems were, as we all do, but finding the evidence and the space and the time to look at it was always difficult because we were always rushing around and being busy. So CLEAR gave us that time and space, and it also gave us the data that we've all talked about this afternoon, and it was just amazing that the difference and the shift in reception that we got when we wanted to introduce some quality improvement on site, when we could show the clinicians the data that we had. One of the success stories that we had was the frailty cohort of patients that we had that came through the department. We'd got a new frailty service, and the staff worked 8 till 8, 7 days a week, the frailty nurses, and they met the patients in the department, and they would do a full comprehensive geriatric assessment, and then hopefully do some admission avoidance, or they'd admit the patients if they needed further treatment. What we found with the data was that we found that there was a huge demand and a huge peak of attendances at tea time. And that was often with the ambulances bringing the patients in, and often carers calling for help at lunchtime. The service often finished taking referrals at 7 p.m. So we had a lot of patients that spent the night in A&E because they were just stuck in A&E with no service, specialist service there. We were able to show the directors and the senior leadership team the heat maps that we could get from the data that we got from CLEAR. And we were able to change the workforce pattern of the frailty team. And now the service is till midnight. And we've seen a huge reduction in length of stay of patients that have been brought into A&E, and also the performance of the department, as well as the overcrowding and the congestion that it can create in an evening. So that's our story. We've got loads of other stories from the data that we got at Huddersfield. And everybody wanted us to do a little bit project with, with all other things, which was really good. But yeah, that's my story. Thank you.
Thank you, Claire. Always good to have a case example that's fresh and is making a difference to people on the ground, both in terms of the patients not hitting ED and being managed differently, but also in terms of the supporting the workload so that the people in ED can then manage the patients that really do need to be there at the time. So great story, thank you. Our next speaker is Dr. Andrew Donovan, who's the Clear Delivery Lead and Consultant Anaesthetist. So Andrew.
Thank you, Patrick. Thank you, panel. Thanks for having the opportunity, giving me the opportunity to talk today. As Patrick said, I'm a consultant anaesthetist down in Taunton in Somerset, and we were the lucky recipients as one of the first CLEAR programs or projects where we did a project in ED. So I'd just like to give you a bit of background about myself. I'm a consultant anaesthetist who has an interest in data. I've been involved in procurement and in installation of big IT projects, including some of the Cerner and the IT systems that are associated with that, and a change from Cerner to something else, which I think we're the only place in the country that's done that. And from that, we had quite a lot of data, and I tried to bring that to my department to try and improve quality by putting that data in the hands of the clinicians. And that's where I really understand what Nav was saying about, if you can give quality data to clinicians so that they can see and own that data and understand why they're collecting it and act on it, you can really empower some great change. And that worked very well for quite a while, but it is just one piece of data in one area. And it wasn't until a few years later that I was given this opportunity to work with Clear, and it was on seeing John's presentation and the possibility of the things that you could do with the data. I realized that this was a very powerful tool, and with the right framework around it and the right team, you could make some really amazing changes by empowering clinicians and engaging them with understanding what's going on with their department, and also match up those stories that they're always telling you with good data that they can all work from. So we did an ED project, as I said, and that led to a multitude of changes, which unfortunately clashed headlong into COVID. And so the timing of the implementations was what made things very difficult. But the resounding message from that experience, and the one that when we presented that to the board that they took away, was that we had managed to engage clinicians at every level with that process by bringing them, showing them the data and engaging them in that change process by enabling them to ask questions of the data and see what it showed and help them understand why their stories were the way they were, enabling them to come up with solutions that they could then work on the implementation and see implemented. But I just wanted to share with you a little story that happened after our initial project, because and I think this just demonstrates the power of being able to have real-time access to hospital-wide data that you can share with individuals. Our emergency department was, as most departments, very overloaded, and their feeling was that there was exit blockers to the department, especially in the acute admission wards in medicinists, etc. And in our second project, we were starting to look at that and engaging with the clinical staff on the what we call our AMU, which is acute medical unit. But on that acute medical unit, they had their own data, and they felt that there was problems coming into them from ED, and they didn't necessarily think that ED was. They thought ED was a real problem, and vice versa. ED thought AMU was a real problem. We went to the AMU consultants, showed them our data, compared it with their data, and they realized that they were the same thing, which actually changed their focus, because they were very mistrusting of what we were showing them initially. But when they realized that they were actually the same thing, but also with that, we had the ED data as well, which from that project, so we could show them that. They then understood that what they were looking at was only just one half the story, and by showing them that full story, we enabled them to trust what was going on in ED, to trust their own data. And then the ED consultants and the acute medical consultants started to talk and really collaborate, realizing that they were actually talking about the same problems from slightly different perspectives. And it's having this agnostic data that you can show to individuals. They can query it then and there. They don't have to go away and collect it and audit it, and it takes months through a process. They can do it then and there. That enables that sharing, that understanding, that collaboration, and you get fantastic clinician buy-in with the results that we all know that that can bring. Thank you.
Brilliant, great synopsis, Andrew, of that work in Taunton, and great to hear that you can bring colleagues together through the power of data on a common problem and find a solution once you're both on the same page using that data. So great example, thank you. Our final speaker is John Jeans, who's the national lead for the CLEAR programme. So over to you, John. And you're on mute.
Phrase of 2021, isn't it? You're on mute. The joys of tech. Thank you very much, Patrick, and thank you very much, everyone, for sharing your thoughts. It's been really great to hear all the different challenges, but then some of the solutions that have been implemented, especially over the last 18 months, which has been really quite tough. There's clearly going to be a long way to go, I think, for us all over the coming years, given what's happened over the last 18 months. And I think just going back to a couple of the points that were made, Nav, you made a very, very good point about the need to engage frontline clinicians and to support system-wide working by look at patient cohorts. in an evidence-based manner. And Patrick, you made the point that we need to be thinking about skills and how we treat those patients based upon, with using the right skills, agnostic of potentially the staff groups that deliver them. And I think Sukhmeet made the point is that there's so much work that goes on within the NHS that is sort of looking upward and not necessarily looking downward and engaging with staff and frontline staff and engaging using that data in an effective way to drive change and doing so, as Pramod said, in a collaborative manner, which gets staff doing what Andrew described, which is to bring people together in a collaborative and supportive manner, using data effectively, then also having that sort of air cover and executive sponsorship as needed. And I guess the final point that I wanted to just reflect on was how Arvind mentioned the need to build leadership amongst clinicians. And I think the most important part of that for me personally is the point that Kathryn alluded to, which is how you think and how you communicate to solve the complexity of the challenges that we face. And for me, to bring that all to life, Patrick alluded to some of the mental health work that's ongoing, and it's difficult for me to share the work that's ongoing because it's not sort of fully been cleared by, or not fully sort of been presented formally within all the organisations as of yet. But just to sort of take all of those points that people made together and just try and crystallise it in one of the projects in an anonymous manner. There is a team in the mental health programme right now that's comprised of an ACP, an OT, and a nurse, and this team is doing fantastic work where they've identified challenges in a CMHT and looked at solutions that span both from primary care and secondary care to help change the skill mix of the team using staff that we do have in the unregistered workforce as well as the registered workforce, and thinking about how the model of care can therefore change so that patients can be seen quickly when they need it. Going back to the point about if you're thinking about it as a customer, you as a patient, if you've got a mental health crisis, you don't want to be waiting 3-4 weeks. You want to be able to speak to someone now and speak to that person who can look after you well, and that isn't always a registered member of staff. Sometimes it can be an unregistered member of staff. So when you other changes from the team about how they can work more collaboratively with primary care, shifting certain types of activity away. Now, I don't know what the outcome of this project is going to be, but if you stack up all those different factors, you've got a change in the unregistered workforce that can see patients more quickly. You've got activity shifted out into primary care. You've got patients that can, a caseload or a waiting list that can be reduced substantially to near nothing as a result of it, potentially. And you've got staff that are freed up more time so that they can do the clinical work, which is what they've signed up to do, as opposed to less of the more administrative tasks. And all of this is done by a group of frontline clinicians who had never had this opportunity to look at this stuff until 6 months ago, but have been empowered by the data and their own sheer hard work, fortitude, and resilience to come up with a set of solutions that I'm hoping will be presented and get sufficient buy-in to make the relevant changes. That's just one example in mental health, and there are multiple other projects going on like that as well. And I think if we go back to the ethos of kind of why we're all here today, if we can continue to have supportive conversations that build capability in colleagues, and where we can give people the appropriate tools, training, and time so that they can go and deliver this kind of work and the air cover so that they can do it well, then we're all going to be in a position where we're doing the best for all of our patients and helping people think more effectively along the way. This is the aspiration of the CLEAR program, and obviously the aspiration of everyone who's on this call today. So, yeah, I just I'll stop there. I think I'm going to start rambling, but thank you. Yeah, they were my thoughts, and thank you, Patrick.
Thank you, John. I'd like to invite panel members to get into a bit of a discussion for the next 10-15 minutes before we open up more wider to the audience for Q&A. Just on this very issue, if you reflect back, Henry Ford, when he asked his customers, what do you want to move your transport quicker? It was faster horses. They didn't talk about the motor car, obviously, because it hadn't been invented. But actually, I think we've got the opportunity now in the NHS or healthcare generally across the world to think quite differently. And when at the moment, if you ask people in the NHS what they want more doctors, they want more nurses, they want more X, Y, and Z, because they're thinking in that forecasting forward about what is here and now. And I think Kathryn's point around we need to think differently, and we need to think a panacea differently about what healthcare might look for the future for us as the customer, and what would we really like to happen if everything was wonderful. And then I think we have to respond to Nav's point around health inequalities growing rather than getting better. Throwing more doctors and nurses at it is not going to change that health inequality. It's probably going to make it even widen. We've got to think about population health. And then all the other points that have been made this afternoon around pathways, pathway management, signposting, getting people through a system quicker or into a different type of system so they're treated differently. I think Sam made the point around you cut through the primary care, urgent care, secondary care boundaries, and just you are where you are to get the treatment you need or the advice. And all the points seem to come back to data. So I think the point, and blown away, Suki, by your point you made around Analyst X, the fact we've got 16,000 data people now talking to one another, sharing code and collaborating is absolutely fantastic, because that has to be a door opener to some of this. What I think I'd like to put to the panel is, where do we start with this? Is it data? Is it getting clinicians to use data? What are the things we need to get this movement going so that people don't just talk about let's throw more doctors and nurses at the problem, because that's the equivalent of faster horses, but actually something that's quite different. So I put that to the panel, and put your mitts up so that I can bring you in. Sam.
Well, what a fascinating discussion. And if I think back to what's happening right now in the system, we have widening inequalities, not just in healthcare, but every single part of society, most of which we can't solve within a health system. We look at the balance between expenditure of preventative to curative health in the UK. We spend the majority of our resource on curative healthcare. And of course, all of us in our services, whether we're going to them as patients or managers or clinicians, are faced with the same issue, that the burden is increasing, whether it's the burden on the clinician or the burden on the patient. And for that, we have to try and change the way in which we think of the system. No longer should it be a paternalistic system which is controlled by any of us, but perhaps we have to flip this round to one which is we are entirely the servants for the patient, but actually to help them access a form of prevention that we haven't yet done in the UK. And what I mean by that is helping people understand the likelihood of illness much earlier in their lifespan, to the point at which we start proactively supporting people to be the agents of change in their own lives. And it's not something we really do. If we think about it, we react to people's illnesses as they present to us at a point later in life, whether that's in an acute setting or primary care. But what if we flipped it around? What if we made it more accessible for people to have what some people might say is over treating, but others might say is actually diagnosing illness much earlier and using data in a different way, using data that comes from other sources, combination of environmental data, genomic data, and lifestyle data, things that we don't do. So I'd like to see a system where we flip round to being the servants for the patient, for the citizen, make them the agents of change, and use a different set of data to help prevent that sequelae and progression of illness.
Great point, Sam. Interesting how quickly we, the British public, got used to online banking and not going to the high street to get cash out and using a plastic strip rather than using cash, etc., and all the societal change that has come about from that. But still, we're in a healthcare system where we must see a face-to-face person to get a diagnosis. And I'm sure people may argue back healthcare is different, but I'm not sure it is from a psychological point of view in terms of the change management. But great points. Nav.
I know Arvind's got to go soon, but so I should let Arvind go first, if that's all right, Arvind.
Of course. And then Arvind, do you want to go first? You're on mute.
Yeah.
Sorry. I thought I had unmuted myself, but not really. Right. So no, thank you very much. Now, the thing is, in terms of the cost, I mean, we can throw as much money as we like, but we know it from our experiences in this country and also across the pond in America that cost does not make healthcare any slicker. If anything, it just creates much bigger and much complex models, and we waste more money and everything. So I think it really needs to be data driven, and it really needs to address where the problem is, and that is right at the grassroots level. We need to drive our healthcare. I mean, sometimes I question this thing. Why do we have hospitals? Why do we? I mean, we're still stuck in those old 100-year-old models. That hospital is somewhere which is like a sanatorium. We have to go recover in there. Why? I mean, I ask my question that if a healthcare is given to me right at my doorsteps, I would prefer that. So I think it's a lot of this thing is to change the way we think, and then the way we lead change, because obviously we might be having a good way of thinking, but if we cannot translate that change to the wider NHS, then all those thoughts which we have today, even as a panel here, will be of no use, because we are ahead of them thinking all those things, but we need to bring everybody together to think at the same time. And I think that's where the biggest challenge lies. And that's why I always say that we need strong leaders to move things in the right direction. I'm now sort of reaching that stage where I sort of feel that if it carries on, we just will not be able to deliver things. And like we had the COVID moment for the NHS, I would like to say it was a COVID moment because everything changed overnight. We started to think differently. Why can't we have more COVID moments? And that drives change.
Great point. And for those of you who have read the Topol report that was published in 2019, Eric Topol talked a lot about actually, do we really need hospitals in the 21st century? The technology is already there to put people on sensors, monitors, and actually look after people in a very different way. So actually, only the very, very few would need to get into the four walls of an establishment with healthcare professionals working. So very, very strong points. Nav. This may appear to be a series of disconnected thoughts, so forgive me, but I just kind of, these are things just kind of I've been reflecting as I'm hearing the great contributions. So firstly, as you probably could gather, I have a tremendous amount of admiration for somebody like Arvind, and we've spoken before, haven't we, Arvind, about some of these things, and I wanted to just completely endorse the point you're making. Throwing more money at a problem doesn't improve outcomes, so let's just make that very clear. It's been very elegantly demonstrated by Muir Gray and colleagues. The more money you put into a program, even clear, by the way, sorry, John, I didn't mean to upset you there, doesn't necessarily improve outcomes. So we have to be thinking about what's the sweet spot and then what's the value that you get, right? So let's change the conversation from money to value. So the second thing was data. I'm probably going to upset our data friends here, but can we be clear what we mean by data? Because a lot of the stuff that I see in the NHS, frankly, and please don't take this the wrong way, is meaningless to those of us on the front line, right? It is pretty meaningless. So where, for example, would I find out who the homeless population is that is using a food bank? Who's recording that? Where is that information? It's not within the NHS. Who's got multiple comorbidities that kind of come from a particular postcode where we know there's knife crime and other situations which end up with people turning up to A&E on a Sunday night? Where's that information? Sorry, no challenge to anybody on this call, but what I'm trying to say to us is we've got mountains of data, linear data around diseases and
algorithm-driven information, which is very helpful up to a point, but it doesn't necessarily get us into that population health space, which is where we're thinking about broader determinants, what's driving demand, and how do we address those things at source. So the commonest reason for people turning up to an A&E, where I'm a non-executive director, is mild to moderate mental health issues, right? It's not because GPs aren't giving enough appointments. It's not because they're, so can you see how the NHS responds to poor information in a completely illogical way? And this, so the single biggest correlation between A&E attendance is deprivation, not access. So, how are we kind of telling these stories to people so that we don't end up, as Patrick said, we need 50 more emergency medicine consultants or 300 more, people of whichever species, because actually that's not going to address the problem at source. So, I kind of wanted to just kind of reference those thoughts. And of course, if anyone wants to challenge me back, feel free to do so. But essentially, the point that's being made here is about how we enable people to look after themselves better. Quite a lot of demand is medicine-initiated demand. All right, so things that we do as clinicians creates demand. So, how are we capturing that? How are we kind of looking at those sorts of factors which enable us to think about things slightly differently? So I'll leave that for people to pick up in the conversation.
It's really, really good points, Nav, and interesting. Another scary piece of fact: the British public, 43% of them are health illiterate, in terms of they cannot navigate the simple health instructions that are provided in your medicines, etc. So if it's a 43% illiterate, that's one hell of a challenge we have in terms of our own educational need for ourselves as citizens to understand how to navigate healthcare and to understand the simple information that's put in front of us. So great challenge, Nav. Pramod.
Thank you, Patrick. Nav, if I may expand on your theme around health inequity. So it's not about throwing more money, as Arvind says, but probably throwing money or moving money to the right part of the system. So if you look at data, and data can help you with that. As an example, going back to one of the London boroughs, in Harrow, we have 2% of the population over the age of 85, occupying 22% of hospital beds. 1% of the population in Camden, pretty much all restricted to a few postcodes in South Camden, account for about 15% of the healthcare spend in Camden. And that gap is widened due to COVID. COVID, if anything, has had an unequal impact. So when we look at population health, it's important that we look at access and digitization of access in the light of health inequity. And we are conscious that we may be increasing the digital divide through some of the measures we do. If we are not, as leaders, constantly looking at the data that allows us to understand whether the marginalized, the deprived, the socially, the wider determinants of health and its impact on the health outcomes are being appropriately measured. So I think I was just going to mention that point really. And that point is really relevant to staffing and burnout in the NHS. So the BMA report has a lot of primary care doctors would say 9 in 10 have burnout, about 50% have burnout leading to depression, anxiety. And that's not different in the secondary care system. So if you really want to balance the work life, have the right outcomes for the population, you need to use data, which is there, and Sukhi and people like that would be able to give the right data, which allows us to make those important changes in the system.
Thank you. And do you think our strategy, or the NHS, I'm not saying our strategy, the NHS strategy for integrated care systems that brings health, local authority, third sector, other partners together, is at least an opportunity to start looking at data in that way to help challenge this and work with data to bring about changes across boundaries?
I agree. I think there is increasingly the recognition of the health inequalities and the wider determinants of health. And I think NAPC has championed that for many years. But now that seems to be, in the NHS long-term plan, ICSs have taken that on board from what I can gather. But it needs to be moved from strategy to an executable action plan. And I think we need to be able to measure the right thing. For years in the NHS, we have measured process, so we've improved all of that. But, you can measure the wrong things and it leads to wrong outcomes. So it's about getting the right measures, I think.
Fantastic, thank you. Kathryn and then John.
I mean, this is just a fantastic conversation to be part of, and so much sense being talked, really. I think, Patrick, for me, I just wanted to come back to your provocation, which was, why do we spend so much time thinking and obsessing about faster horses? So forecasting rather than, and just wanted to offer an observation. I think part of it is the ramifications for us individually and collectively in doing foresight work, in radically reimagining what that could look like, is something we don't spend enough time talking about, the consequences of it. And I'm thinking particularly about things like loss of identity, loss of things that may, for clinicians or managers or others, have been markers of status and success, for things that we have been rewarded for. I'm not a clinician by background, I'm a barrister by background, very similar set of rewards, status, hoops, and ways of developing our knowledge, experience, and space to operate in the world, which could potentially be challenged. One example, I think maybe it was Andrew, you were talking about, if we clear the space, and certainly in the comments that were made at the start by Arvind, if we clear the space for clinicians to focus purely on clinical work and not do other things, we need to ask what we lose from that, as well as what we gain in terms of space, in terms of relationships, in terms of any other factors. And I just wanted to share one small story. I was doing some leadership development coaching recently with a person who's been appointed to a CEO role in an integrated care system. And this person was what I would call a BlackBerry person. So throughout most of the sessions, the person was, tapping away and kind of partly engaged. We did on the third day a session on whiteness. So what is whiteness? How does it operate as a system in relation to discussions around race and racial inequalities? And there was a moment, another person was leading the session, but there was a moment where the BlackBerry colleague went very quiet and very still, and the energy shifted and everybody looked at her because we could sense that something had changed. And she said, "I've just realized something." And I said, "What have you realized?" And she said, "This work is really important and I have to have a role in leading it. And I have no idea how to do it." And she burst into tears. And it's almost that the CLEAR program, other programs, other moments where people can pause and reflect on the cost and the daunting challenge of some of this work, as well as the opportunity that stands in the way of us seeing Ford's car and means we're much more comfortable talking about horses.
Really, really strong point. Thank you for sharing that story. There's something here about compassionate leadership, isn't there? And how, with the acceptance that we've got massive burnout across the NHS at the present time, by introducing compassionate leadership where people really start to be empathetic, understand from a very diverse point of view what people are saying from the professions, from where people sit within their own individual roles, but then start to rebuild the thinking and that understanding about what they can do to bring about change within their own organizations and what they then might need to help them bring about and deliver that change. is hugely important, and we probably don't spend enough time thinking about not just the basics of compassion, but actually the logistics of making it happen from a leadership point of view, of which everybody on this call today has a role. So really, really strong point there, Kathryn. Thank you. John.
Thanks, Patrick and Kathryn. It's a very difficult, I mean, it's a very powerful point that you gave, and actually one that I don't think I can. I was going to make a similar point, and I'm not sure I can do it as well. So, but the point, the issue that I want to raise, and I just echo what you have said, is, and it alludes to the point that Suki made earlier about culture. So if we are going to do these radical things, such as the Mercy virtual example that Sam's put into the chat, in order to do that well, we need to create headspace for people to do this kind of brainstorming, and that's got to be, in my opinion, it's got to be consistent headspace over time. This isn't something that, you know, you're not going to take someone who's been embedded in a profession for and had all the rewards and all of their thinking around themselves locked in for, you know, 15, 20 years, or even 5, 10 years, and they're not going to be able to see things radically differently overnight. It's a journey for some, and I mean, for me personally, it took the experience of my dad becoming unwell before I was able to start to take a step back and look outside the box, look outside of myself and look outside of the profession. So I guess what I'm saying is that I completely agree. We need to look very, very, very hard at who we are and what we're doing and what does it actually mean for our patients, because otherwise, why are we here? But I guess we do need to give people the time and space and appropriate support so they can do that. And that is actually quite a significant cultural shift in health and care. This is this kind of developmental work. It's not always there in a standardized manner for every different person that works, and that's something that I think we all have to work at to try and support our colleagues to do well. Yeah, I guess there's a huge amount of potential here, but we'll have to work very hard at the cultural enablers to make sure that we can do these and deliver these changes over the coming years, because we have to. You know, our patients deserve it.
Thank you, John. Can I now open it up for questions from the wider audience that's listening in and participating today? So, question come from Sarah. Are there any data sets around personal communication habits or examples where changing communication habits have helped? Many people unwittingly learn and run strong codependency communication habits. Good point, Sarah. Who in the panel would like to answer that one or take that one on? Data sets around personal communication habits. Nav.
Probably tell I'm coming from the qualitative dimension on data, and so forgive me if this sounds a bit parochial. So I'm not even sure what data sets would be relevant here, but I wanted to make 2 points about communication. One is if we're just talking about culture, then I think we've got to lose the culture of what I call dumping syndrome, and I don't mean gastric dumping. I mean dumping from one sector to the other. So the sort of sense that not my problem, go and see your GP, or GP saying not my problem, go to A&E, or someone saying not my problem, phone social services. So that culture of not my problem is, I think, a real barrier to collaboration. And so could we reframe the language? And you know, when I hear people saying we're really proud, we've shifted activity into primary care, or we've shifted activity from one department to another, what is that? What message does that give to a beleaguered sector? You know, other than I appreciate we're doing it for the right reasons around, you know, but I think we need to look at our language, and I think we could reframe the language around where's the best value to people for the, you know, for that type of intervention. And then I think the person asking the question was saying that when we look at when one of the biggest determinants to outcomes is what we call unwarranted variation, and that unwarranted variation sits within the space between the communication between a patient or a person or a carer with a healthcare worker of whatever sense, and some of that unwarranted variation sort of sits within the kind of area of not following the right guidelines, but a lot of that unwarranted variation sits in the space where we're not taking sufficient account of the needs of the individual when we're trying to think about what the problem is. So whether that's a function of not really understanding their needs, not taking account of the broader determinants of health that Pramod was talking about, really figuring out what we need to do to support them to live a healthier life, those things contribute a large chunk of the unwarranted variation in the encounter. And I wonder whether we focus enough on that when we're talking about communication skills, because I think what I hear is all this kind of ramp around evidence-based healthcare delivery, which is important, but it's not necessarily always important to the individual.
Thank you, Nav. Great response. Does anybody else want to continue on that thought pattern? Or can I just move that slightly then, because we're being asked by Annabelle Beasley, does the panel think the ICS working will enable some of the change that the panel have been talking about? Are we going to be able to move it about some bottom-up change? So some thoughts on that, which does pick up on Nav's point around system dumping and actually removing boundaries. Sam?
Perhaps a slightly controversial response on this around ICSs.
Controversial's good. Controversial's good.
The concept of ICSs, of course, is fantastic. Most people will probably agree that closer working, the integration between providers, clinicians, commissioners, managers across different parts of the system, fantastic. However, there's an elephant, and that is we still have a system that is dominated by one part of the system, and we're expecting a range of service providers to come together. And we still have another elephant, which is that we haven't dealt with what do we do with social care, public health, and local authority in this new world. They are still the poor cousins that are being invited to the end of the party. And so whilst I want to see integrated care systems achieve some of this, I think the reality is the centre will find it very difficult to let go of control. And we're already seeing that right now from the way in which the Department of Health in England is operating. I think the infrastructure that we need across the NHS, across health and social care, still doesn't exist as at today. And I still think we have an issue around leadership and at a local level around the integrated care system. There isn't recognition around the balance of leadership, collaborative leadership, and having the right leaders for the right outcome. And until we move to that and away from the process that we're still driving the system through, I don't really feel or see that ICSs are going to succeed. I'd love them to, but I am probably a little bit negative.
Okay, thank you. That's a good point. I would say from a workforce perspective, we need to make sure we start using the same language, and the healthcare can't be seen to be doing things to social care. Social care needs to work, we need to work with social care to understand the language, understand the skills and capabilities they require, and also help influence, I suppose, the issues, particularly around pay, because we recognise whatever happens, health will always steal from social care when it comes to the hands-on caregiving until social care can afford to change that, and that's clearly an important part of this change. Suki.
So I'm perhaps going to have a less controversial opinion on integrated care systems. But Sam, taking your point around we're probably not doing all we're supposed to be doing, and that's partly due to the enablers, leadership, etc., and so on. I think we could either look at it as a problem that's too big to solve unless we do something radical, or we could do what some disciplines are trying to do, for example, in data and analytics, which is rather than solving the entire piece, can we make the changes that we would like to see? So some of the stuff that we've done during the COVID pandemic, had we been left to our own devices, no pun intended, we'd have never really been able to do much of that. But we've done it, and we need to build on those technologies, the culture change that it's brought, move away from performance management, more into the predictive space, all the stuff that John and the CLARE program talk about. And I think in data and analytics, perhaps, we're a bit more fortuitous, because I almost find as analysts we're quite organizational agnostic or title agnostic, and we just want to solve some really crunchy problems. Give us the data and we'll get on with it. And I think we've been riding that wave at the moment. So at least from a data and analytics perspective, I think we're probably, it's definitely not solved, but we're probably not at step 1. We might be on step 2, Sam, of this 10-step ladder.
Can I push back on that, Suki, to ask, do you think analysts are using the digital technologies, AI in particular, sufficiently to really move this agenda forward and to get people in the system, particularly clinicians, excited about the data that's there and what they can do with it, particularly from I suppose, a population health perspective and a care pathway perspective?
Yeah, so 2 points there, Patrick. No, definitely. I don't think we're doing it at scale as we should be doing compared to other industries. There is the whole skills and capability work that we're working so closely with Health Education England on what does it mean to be an analyst? How do we track that career path for them? And there's a whole suite of interventions that go around that, which we could spend hours talking about. But your point around population health, I think one of the chasms that we're not discussing is this big chasm between population health intelligence or insights, if I'm being generous, and the operational workflow and decision making, because we're actually a system that's enshrined within operational delivery performance management. So until you marry the Cinderella part of the specialty with what is reality, you're not really going to make headway. And I actually think that there is a great opportunity to do this going forward with not just empathic leadership, Patrick, as you talk about, but leaders who have conviction, wanting to do something very different, who will probably not be appreciated for it in the short term, but in the long term will make significant gains. But having an equal measure of conviction and the ability to really want to do something differently, I think you might be onto something there then.
Great, good point, thank you. Nav and then John.
Mine's just a very quick point to the question about will integrated care systems make a difference, and I guess it just makes me think that integration or integration of care is not a thing. It's actually, it's a relatively meaningless concept unless we think about what the purpose of integration is, which I think, in my view, is absolutely to improve the health and well-being of populations. So the journey for me starts with having a granular understanding of where the health disparities lie within whatever context, whether it's a neighborhood, whether it's place, or whether it's the whole integrated care population, and then targeting and focusing resources in the broadest sense for those communities that need it most, so that we avoid what we currently have, which is a one-size-fits-all approach to everything, to actually a one-size-fits-all approach to people for whom that approach means something or make a difference. So to your point about digital access, Patrick, in East Merton, where I work as a GP, I know a large chunk of the population does not have access to things like Wi-Fi or mobile phones or iPads or whatever it is. So unless we're going to hand those things out to people, or we're going to kind of figure out how we create the right environment for people to access systems in that way, it's a rather challenging strategy. Say everybody must go online in order to access whatever it is. But it can be solved. But we just need to be much more sophisticated about understanding what people's needs are, so we can build the right thing in place, and not just assume that everybody can do the same thing in the same way.
That's great observation about digital inequality, Nav. And I know that there was a piece of work done a couple of years ago, I think it was in Sunderland and somewhere in the southwest, where there was major digital inequality, and they provided the patient group with iPads, iPhones and everything else, and actually demonstrated not only did they improve the digital literacy of the local population, but actually really did improve health access for those individuals by making that kit available. So it certainly can be done, but how far it can be done at scale, yet to be seen, but a good point. John.
I just wanted to, thank you, Patrick. I just wanted to pick up on the point that you made about using AI well, which also alludes to the point that Nav made around, and Suki made as well. There's a couple of barriers that are quite difficult to sort of overcome to use AI well within healthcare. One is data is, I suppose the first is knowing what's data that's actually collected, because we collect loads and loads of data and we do not touch the sides when it comes to using it. So, you know, Nav asked some questions earlier about, I would like to know about, you know, how population health and knife crime works. Actually, you could do that piece of work relatively easily. The data's all out there. But it's about having the knowledge and skills to get the people who know where the data is to bring it together. Then there's a second part about making sure the data is of a reasonable quality. And that is actually really, really difficult, getting the data clean so that it can then be used for AI and ML to work well. One of the things that we found with doing the clear work is that actually we spend a lot of time helping trusts know where their data is, and then how to actually utilize it and get it cleaned up to the point where it can then even go into national submissions. So correcting some of those sorts of things. And then I guess then to finally sort of bring it up to the point, the final thing that is we will have to solve, but is a very difficult solve, and something that ICS may help with, is the governance around sharing data. Because to use AI and ML well, we do have to be able to link data sets. We do have to be able to do that across providers. And we have to use data that doesn't necessarily normally come into national commissioning data sets, be that workforce or activity. So not only do we have a challenge for skills and capabilities, we also have the cultural issue, which is the point that was made earlier about enabling people to put in data well so that it can be used well. So, you know, you're not doing what I used to do, which was just type any old thing into a box. You're making it consistent and cogent and clear, and then taking that, so it's using the data, putting in the data well, having appropriate governance around it, and then having the skills and capabilities to be able to use AI and ML in a way that can actually make tangible differences to patient and population outcomes. And all of the building blocks are there. And I think ICS is actually will kick the ball in the right direction with regard to this kind of work. I've just reflect a question back, I suppose, is from doing this work, I can't see quick wins to sort of really taking apart, you know, I can't see doing this work at scale in terms of deploying ML across a range of different areas in, you know, deploying the right ML solutions in a range of different areas across different clinical areas, across different organizations. I really struggle to see how that could be done fast. I can see how it can be done in pockets well, but to do it at scale, I think there's probably a journey of several years. And I don't know if that's me being unreasonable or short-sighted. I just guess I want to kind of ask a question back, which is, if you could flip it on its head and you did have all of this access straight away, is that actually something that we can attain, or is it a journey that is going to take a couple of years? And I don't know if that's a reasonable thing to think.
My sense, John, is this technology is here. We've got 183 different AI pieces being used across the NHS at the present time, and that is growing. And the opportunities to then use it to drive data and to drive clinicians thinking differently about how they use data on their own population groups, I think is here, and is something that's going to drive the way we deal with, I suppose, clinical productivity, if you use it in that sense. How we do make better decisions is going to move very quickly in the next 5 years, would be my sense of the speed. I think we've got another 2 years window of it all padding through, but then after that, I think it's going to move very, very quickly, just because the technology is there and we've got people that know how to use it. It's around how quickly we can then upskill people to feel safe and confident to use it, would be mine. I'm conscious we're now at 3:30. There was a final question from Alexandra around, is it possible to truly adopt a skill-based approach given the value placed on professional identity? John, I don't know, in your summing up, whether you want to answer, try and answer that one, or provide us a response as you sum up the afternoon.
I think that's a sort of a great question. So to truly adopt a skills-based approach, given the value placed on professional identity and other related barriers, I think the answer, I guess, I really would welcome other people's thoughts here.
Your Nightingale experience, John, probably is proof that it can be done.
You're right. You're actually, Patrick, you're entirely right. When needs must, people do it. and you can work outside professional boundaries, and people will crack on, and they will think, what does the patient need? What are the skills that need to be trained? And who are the right people to do that? And so, yes, Alex, it can be done. It makes people uncomfortable. People have to really think outside the box, and so it's only so to get these kinds of accelerations in thinking. It's times of crisis are able to promote that type of thought. And I suppose, you know, COVID has a lot of clouds, but there are some silver linings. And this ability for people to think outside the box, do things differently, create communities of practice, share code, and to work differently, using the right skills to right patients. This is the kind of things we have to hold on to and make sure that we use over the coming months and years, because our patients are going to need it. We've got a lot of demand, and we need to think differently about how we staff. On that note, Patrick, is it safe to say that it's a fair to reasonable time to sum up?
So.
Brilliant. Well, I guess I just wanted to say, appreciate that there's a lot of people who've given their time to come and be part of and also listen to this conversation today. And it's been quite inspiring for me to hear the conversations and the thoughts and also some of the stories about how people are doing great things to drive change within the NHS in a way that improves patient care and also enhances staff experience. And I think we've got some really exciting opportunities over the coming months and years to do things differently, provided we can create the headspace for ourselves. As Patrick said, I think that compassionate leadership is going to be fundamental to doing it well. Without, I guess, further ado, I'll just thank everyone for the time, and there'll be a recording sent out to everyone who's been part of the session more widely. If anyone does have any questions or any thoughts, please feel free to get in touch at any time when we can share contacts with the panel as appropriate, so we can manage that centrally through the program. So thank you very much, everyone, and I hope everyone has a great afternoon.
Thank you very much, John, and thank you for everybody's contributions this afternoon. And have a good afternoon. Take care. Bye-bye.